Somatic symptoms and dissociative disorders is coming from the Townsend textbook, chapter 29. Somatic disorders are expressions of stress through physical symptoms. These symptoms may be indicators of psychological and emotional distress that the patient may be going through. Instead of feeling anxiety, depression, or irritability, some individuals with emotional stressors may experience pain, paralysis, unexplained skin rashes, and other symptoms. What is somatic symptom disorder? Well, it is a disorder characterized by physical symptoms suggesting medical disease but without demonstrable organic pathology. The person with somatic symptom disorder is going to focus on physical symptoms. Those physical symptoms can be things such as pain or fatigue. They will focus on these symptoms to the point of excessive concern about the symptoms. They become preoccupied by the symptoms, and they are fearful because of the symptoms they are having. When they go to see the healthcare provider, that healthcare provider is unable to make a clear diagnosis explaining the discomfort that the patient may be feeling. And oftentimes that leaves that patient with somatic symptom disorder feeling discounted and misunderstood because their illness is real to them. There is criteria for somatic symptom disorder that's found in your textbook on page 605. It's not important that you know about each of these diagnostic criteria for the somatic disorders and dissociative disorders that we will be talking about. Just know that the psychiatrist, the psychiatric nurse practitioner, psychologist are often using this diagnostic criteria as a resource for diagnosing mental health disorders. Some predisposing factors for somatic symptoms disorder include genetic hereditary factors. There are some biochemical causes that may be due to increased levels of serotonin, endorphins, that play a role in causing patients to experience pain. The neuroanatomic theory cites several brain imaging studies that show that there's actual brain dysfunction going on that can cause somatic symptom disorder. Some psychodynamic theorists view somatic disorders as an ego defense mechanism, that physical complaints are the expression of low self-esteem and feelings of worthlessness. Family dynamics theorists report that people develop somatic disorders because some families have difficulty expressing emotions openly and resolving conflict verbally. In dysfunctional families, when a child becomes ill, the focus shifts from the open conflict to the child's illness and leaves unresolved underlying issues that the family is unable to confront openly. So the somaticalization brings some stability to the family and positive reinforcement to the child because something is being gained when that child is ill. The focus is now off of family conflict that the parents have come together for guiding the child and encouraging the child. So the child is going to continue these somatic symptoms because they are receiving a gain of some sort of help in some way. The learning theorists propose that somatic complaints are often reinforced when the sick person learns that they can avoid stressful obligations or if they be an excuse to get away from unwanted duties. This again is talking about the gain that the patient receives from having these symptoms. Um, the symptoms may become the prominent focus of attention. cause of the illness. That would be a secondary gain that the person receives. And the symptoms may relieve comfort in the family as concern is shifted to the ill person and away from the real issue. And this would be a tertiary gain. So a lot of the predisposing factors are within the person who's having the symptoms. Sometimes they may have these symptoms because it relieves anxiety, but also because they are gaining something from it. And then the learning theory also say that past experience with serious or life-threatening physical illness, either personal or that of close relatives, can predispose a person to illness, anxiety disorder. Transactional model just means that there are multiple factors, including some of the learning, genetics, or psychodynamics. They're saying that it's just a combination of multiple factors that may predispose someone to develop somatic symptom disorder. So let's talk about the different types of somatic symptom disorder. You have probably heard the term hypochondritis and are probably somewhat familiar with the symptoms. The term hypochondritis has been replaced with a more descriptive diagnosis of illness anxiety disorder. Illness anxiety disorder is characterized by extreme worry, extreme fear about the possibility of having a disease. And some of the characteristics of illness anxiety disorder is that that person will have unrealistic or inaccurate interpretation of physical symptoms or sensations, leading them to be preoccupied with and fearful of having a serious disease. They may have extremely conscious of body sensations and changes occurring. Some have history of doctor shopping, while others speak uh, will avoid seeing medical assistance. And some with illness anxiety disorder will have anxiety and depression along with obsessive compulsive traits. Another disorder that falls under somatic symptom disorder is conversion disorder. Conversion disorder is marked by the presence of deficits in voluntary motor or sensory function. Some of the symptoms that they will have with conversion disorder will be neurological symptoms, such as they may feel that they are paralyzed or blind. They may have movement disorder, a gait disorder. The person with conversion disorder may feel that they're experiencing numbness and paresthesia. They may lose their hearing or even have episodes that resemble a seizure. So remember that conversion disorders are usually going to be neurological symptoms that the person has. Look on page 606, and you're going to see some other conversion symptoms that patients may have. They may develop insomnia, where they have an inability to produce spores. They may have seizures, coordination disturbances, difficulty swallowing. They may experience urinary retention, deafness, double vision. They may have asomnia, where they have inability to perceive smell, loss of pain sensation. They may have hallucinations. And then there's a term pseudo where they have false pregnancy. This is a conversion symptom. They present a strong desire to be pregnant. The significance of patients displaying these symptoms is tied to a word called label indifference. And label indifference means that they have absence of psychological distress despite having a serious medical illness or serious medical symptoms. Remember that term veil and distance. And both symptoms of conversion disorders will resolve within a few months. There is a difference between illness anxiety disorder and factitious disorder. You'll see that factitious disorder is a conscious effort, it's intentional. The individual pretends to be ill to receive emotional care and support, commonly associated with the role of the client. This disorder may also be identified as one-child syndrome. This disorder may be imposed on another person in the care of the perpetrator, formerly called factitious disorder process. Some common nursing diagnoses of problems that we're going to see with patients that have somatic symptom disorder are going to be things like ineffective coping because they're going to have numerous physical complaints. They may have a deficient knowledge because they're unaware that the cause of these physical complaints is due to their psychological issues that they're having. The patient with somatic symptoms will have problems with chronic pain. They will have problems with fear, and they'll have a nursing diagnosis of disturbed sensory perception, especially if they have symptoms of the aversion disorder. Now, the nursing care of the person with the somatic symptom disorder is going to be aimed at relief of the discomfort from the physical symptoms that they are complaining of, and assistance is provided to the client in attempting to determine strategies for coping with stress by means other than preoccupation with discomfort. So many of the nursing diagnoses are all going to have a theme. The nursing interventions will all have a theme for somatic disorder as well as the dissociative disorder. So if you look in the textbook on page 616, you're going to see what these things are. For somatic problems, we're always going to monitor the physician's ongoing assessment, lab reports, and other data to maintain assurance that the possibility of organic pathology is clearly ruled out. You're going to review these findings with the patient. You're also going to be honest in explaining to the patient that the illness symptoms that they are having are usually due to psychological problems that are existing. Um, you're going to recognize and express that the physical complaint is real to that patient, even though there's no organic etiology identified, and denial of the patient's feelings is non-therapeutic and interferes with the establishment of a trusting relationship. So you're going to always pay attention to the patient's complaints, and you're going to make sure that all of the complaints are followed up on, that the provider will order tests to rule out medical cause. You will even, as a nurse, give a somatic disorder patient any pain medications that are ordered or prescribed by a physician because the patient's comfort and safety are your nursing priorities. You're going to be mindful in observing that patient and try to identify any gains that the physical symptoms are providing to the patient. Are those gains primary, secondary, tertiary? Are they increasing dependency for the patient? Getting the patient the attention that they need? Is it distracting the patient from other problems that may be going on with him? One important nursing assessment intervention is that initially you're going to let that patient talk about those problems. And then you're going to minimize the time given in response to those physical complaints. You're going to avoid focusing on the client's physical complaints. You're going gradually withdraw positive reinforcement. Gradual withdrawal of positive reinforcement will discourage repetition of the maladaptive behavior. So initially, we allow time for them to talk about those complaints and elements of the habit because this is a way to reduce anxiety and stress for the patient. But later, we're going to start set limits on the amount of time that will be given to talk about the complaint. You also want to reassure that patient that any new complaints will be referred to the physician and that those new complaints will be followed up because the possibility of a organic pathology must always be considered and ruled out because failure to do so could jeopardize the patient's safety. So you encourage the patient to verbalize feelings of anxiety and you explain that attention will be withdrawn if rumination about the physical complaints begins and then you follow through with this intent. Okay? So you help that patient to recognize that physical symptoms often occur because of or are exacerbated by physical stressors. And this is one of the most important nursing interventions as well. The patient has to learn that the physical stressors that they're going through is the cause for the physical symptoms that they are complaining. So if you look on the slide, you're going to always review the lab results, access knowledge. You're going to recognize that the complaint is real to the client, provide pain medication if they need it, try to identify any underlying motivation. What are they gaining from it? And then you begin to taper off attention to the signs and symptoms. You begin to avoid focusing on the client's physical complaints. You begin to set limits on the amount of time that's going to be allowed for them to talk about those physical complaints. And in the meantime, you're going to be discussing coping strategies for the patient, things that they can do to cope with their stressors, their anxiety, their depression, and coping will help to reduce the physical symptoms that they're having. Also, the coping strategies will help to increase the patient's self-esteem. Some of the modalities and treatments for somatic symptom disorder, again, is found on page 623. And these are all related to individual therapy and trying to get that patient to move beyond their somatic complaints. And the focus is on personal and social difficulties that the client experiences in daily life, as well as the achievement of practical solutions for these difficulties. You all know that group therapy is going to provide them with a setting where clients can share their experiences of illness and learn to verbalize their thoughts and feelings. There is a cognitive behavior therapy that is a good strategy for reducing depressive symptoms in clients with somatic disorder. And then the pharmacology is that they will be using the SSRI antidepressant to help them with their anxiety and depression, or they may use benzodiazepines, but they will not use the benzodiazepines long term because they might be addicted. Here is a case study that you can read through. It's about a young 13-year-old that has somatic symptoms disorder. Let's talk about dissociative disorders. Dissociative disorders often occur after a significant experience or trauma. The person with dissociative disorder will respond to stress was a severe interruption in their consciousness. Dissociative is an unconscious defense mechanism that protects the person against overwhelming anxiety through an emotional separation. And the separation results in disturbances in the patient's memory, their consciousness or self-identity, and their perception. For the diagnosis of dissociative disorder to be made, medical and neurological illnesses, any substance use and coexisting psychiatric disorders must be ruled out first. And there are four types of dissociative disorder that we can talk about. And it is the dissociative amnesia, dissociative fuse, dissociative identity disorder, used to be called multiple personality disorder, and the last one is depersonalization disorder that we're going to talk about. Now, dissociative disorders are defined by disruption in the usual integrated functions of consciousness, memory, and identity, and dissociative responses occur when anxiety becomes overwhelming and the personality becomes disordered. Again, there are some predisposing factors for developing dissociative disorder. This is found in the book on page 613. Again, genetics uh, does not have a significant contribution to developing dissociative disorder. Most patients that have dissociative disorder have a history of physical and sexual abuse. For the neurobiological view, they say that there's some type of neurophysiological dysfunction in areas of the brain that's associated with memory. This personalization has been associated also with migraine headaches and with the use of marijuana. The psychodynamic theories believe that the dissociative behaviors occur when individuals repress distressing mental content of their conscious awareness, and the psychological theories point to the etiology of dissociative disorders as a response to traumatic experiences that overwhelm their capacity to cope with what occurs with them. Um, they believe that, especially when they have the disorders that used to be called multiple personality disorder, the dissociative identity disorder, they say that disorder begins as a survival strategy to help children cope with severe sexual, physical, or psychological abuse, and it evolves into a fragmented identity as the victim struggles to integrate and put them out of their personality into something whole. And then the last one is the transactional model of stress adaptation. Again, this means that there are multiple factors that can cause uh, dissociative disorders to occur. The multifaceted reasons why it occurs. Now, according to the textbook on page 611, there are four types of amnesia. We're going to talk about those. Page 611, you have the localized amnesia, where the individual is unable to recall all incidents associated with the stressful period. There is a selective amnesia, where the individual can recall certain incidents associated with the stressful event or a specific Then there is the generalized type, where the individual has amnesia for his or her identity and other history. The fourth type of dissociative amnesia is called dissociative. This is characterized by sudden unexpected travel away from customary places, uh, that the person is just wandering around, unable to recall any of their past. A person that has dissociative may not be able to recall their personal identity, and sometimes they may go on to assume a new identity. Now, the dissociative identity disorder is formally called multiple personality disorder. This is characterized by the existence of having two or more personality states in a single individual. You probably heard of Eve, probably saw movies on the television of people with multiple types of personality. Also, with dissociative identity disorder, the person will transition from one personality state to another. It may be sudden or gradual, and sometimes quite dramatic, in that if it's a child, they will assume the persona of a child and the sound of a child. If they are the opposite sex, if it's a woman that has a male personality, she will assume that male persona. Her voice will sound male. Same thing for the men who may have a woman as one of their personalities. Well, they're going to take on the persona of a woman and sound like a woman or an older man or a weak uh, person, if that's one of their personalities. Or they may have an aggressive personality. Usually with dissociative identity disorder, you will be able to tell when the personalities come through, and by the personality that they will display in the sound of their voice. They may be easygoing, or they may be aggressive. And you'll definitely know. The next topic that we're going to talk about is depersonalization, derealization. In the depersonalization disorder, the person experiences a strange alteration in self-awareness. The person has feelings of being in a dream-like state, and they feel that it's like an out-of-body type experience. Depersonalization disorder is brought on by severe stress. The patient may look at the mirror and the image may look wavy, or the person may feel like they're floating in fog, or the person with depersonalization disorder may experience sensations of slow movement in time. And as our slide said, it's going to be characterized by feelings of unreality. They may feel sensations of changes occurring in the body. They may feel detached from the environment, or they may have a sense of observing themselves outside of their body. All of this is depersonalization, derealization disorder. And again, the DSM-5 will describe the diagnostic criteria for depersonalization and derealization. Now, with types of dissociative disorder, some of the symptoms that you will see are anxiety and depression, fear of going insane, they will have obsessive thoughts, somatic complaints, and a disturbance in the subjective system, especially if they're having depersonalization, derealization. Some of the common nursing diagnoses are problems that are priority for a person with dissociative dissociative disorder. Impaired memory may be a problem if they're having amnesia. If they're having the amnesia, they may also feel powerlessness. They may have risk for suicide if they have dissociative identity disorder with multiple personalities. They may have disturbed personal identity, and they may have disturbed sensory perception if they have depersonalization disorder. Now again, the nursing care with dissociative disorder is going to be trying to restore that person's normal thought process. And you're going to assist that patient again to help them with some coping strategies. And a lot of those uh, interventions are going to be very similar to somatic. So we're going to turn it over to page 616. We're going to look in that second column again. Some of the same things that we've already said is that you're going to be monitoring that patient's assessment, all of their labs. You're going to make sure that organic pathology, medical problems that could cause these symptoms are ruled out. You're going to refer all new physical complaints back to the doctor, and the doctor is going to follow up on those new symptoms that they're complaining of, because the business don't want to put the person's health in jeopardy. You're also going to be assessing the function, the patient's illness, physical feeling for them. Remember, we're trying to see what are they gaining from having memory loss. What are they gaining from having multiple personalities? What are they gaining from having personalization? You're going to identify times when the person is preoccupied with those physical symptoms. You identify the times that they're preoccupied, and this helps you to determine the complaints that are associated with these symptoms. You will convey empathy, let them know that you understand that this is real to them, the symptoms that they're having, and then you're going to help that patient to determine what techniques may be useful for them whenever they experience fear and anxiety. Now, when the patient has depersonalization, derealization, page 616, again, you're going to monitor their assessment. You're going to look for any new complaints that they have and report them. You're not going to focus on the disability, but you're going to encourage the patient to get involved with other things rather than talk about their physical complaints or talk about their amnesia or the derealization symptoms that they're feeling. You're going to maintain a non-judgmental attitude, and you're not going to reinforce the patient's use of the disability as a listening tool. But you encourage that patient to verbalize their fears, anxiety, and help them identify physical symptoms as a coping mechanism that's used in times of extreme stress. So helping them to identify coping mechanisms, even nurses for giving positive reinforcement when they can use a more adaptive way of coping rather than resorting to the amnesia, the realization, depersonalization, or the multiple personality. Okay. On page 619, they talk about if they are experiencing depersonalization, you're going to provide support and encouragement during that time, and keep that patient safe, and support them and encourage them. And then you explain the depersonalization behavior and the purpose that usually serves for the patient. Now let's talk about when that patient has third personal identity. This is found on page 620. You're going to have to try to develop a trusting relationship with the patient and be non-judgmental when you listen to them, especially if there's multiple personalities. That patient may be initially unaware that they have multiple personalities. So, knowledge of the needs of each personality, uh, you're going to have to try to integrate those personalities into one. And this, of course, is going to be done with psychiatry. If you help that patient identify stressful situations that precipitate transition from one personality to another, and then you carefully observe and record these transitions because you'll have to know how many personalities there are within the patient and get to know a little bit about them because it may be more than two personalities. And again, the nurses is seeing the doctor's eyes and monitoring for the personalities and reporting this to the psychiatrist and the psychiatrist to draw out this personality. So you'll use nursing interventions necessary to deal with this imbalance behavior or those subpersonalities. And we'll give an example of one personality is suicidal and the causes of the case brought against the person self-harm. And if another personality displays hostility or aggression, then precautions are going to have to be taken to protect others. So again, when you look at the nursing interventions on the slide, it's the same as the somatic. Baseline assessment, safety is going to be priority, low level of stimuli, maintain a calm attitude, reassure the client that they are safe, try to identify the precipitating events, stressors that are causing the amnesia or depersonalization or another personality to emerge. You're going to assist in confronting these painful issues and help that patient to identify more adaptive coping mechanisms and show them why the maladaptive coping is really what's causing them to have more episodes of amnesia, having a feed for the drama brain and don't know who they are, or when the other personalities become dominant, things like that. So you give positive reinforcement and then of course you identify the source. Treatment modalities for dissociative amnesia. Many cases will resolve spontaneously when the prevention is removed from the stressful situation. For any refractory conditions that reoccur, that they can give IV amyloid is used to help them to be able to retrieve those lost memories. And psychotherapy is used again as a treatment option. Some other things is techniques of persuasion and free association to help the client to remember. And then hypnosis is also been used to help retrieve and mobilize the patient memory. On page 623, again, for the dissociative disorders, the individual therapy will help the client to develop more healthy strategies, behavior, and so the individual psychotherapy, the focus is on the personal and social difficulties that that client may be facing daily. Group therapy, again, helps them to be in a setting where individuals share their experiences, and it is treatment for both somatic symptom disorders and illness Again, cognitive behavior therapy is a good strategy for reducing the depressive symptoms that the patient will have. They will also use SSRI treatment. Dissociative identity disorders, remember we talked about the integrating or blending of all of the personalities. Uh, this will be done by the psychiatrist. They will have an intensive long-term psychotherapy for the dissociative identity disorder. Clients will be assisted in trying to recall some of past trauma details of this process of negation or remembrance skills. This textbook says it's usually painful that the client can cry, scream, and feel that pain that they felt at the time of doing therapy. Personality is actively explored and encouraged to be aware of and strive to get to themselves. Whenever integration is achieved, the individual is able to display all the feelings, experiences, the memories, skills, and talents appreciated their expression.